It's just amazing, and it adds a different flair to her research and to the science. It just makes it so much easier to understand. And you guys are very fortunate that you are about to have this amazing experience in the next few minutes. And without any further delays, I'm going to invite Dr. Azra for a talk. Thank you so much, Dr. Azra, for being here. We are very fortunate to have you here today.
Adab, good morning. Thank you for being here. Absolutely delighted. Thank you to the Vice Chancellor. Thank you to the Dean, the faculty, all of you. And to my friend and colleague, Stevrula Kusteni, who just delivered an excellent presentation. And Shephar has been such a wonderful host, first on email and then now physically. So what I'm going to do is dive right into a clinical case and describe to you a patient story, and then what are we doing about it. So let's look at the case of Andrew. In July of 2016, he developed tingling in his right arm. He started to exercise more, but weakness developed. He was taken to the emergency room, and he was quadriplegic within hours. Now, the neurosurgeons could only remove 90% of the humongous 9-centimeter long glioblastoma multiforme, which is one of the deadliest tumors known to mankind, a brain tumor. So only since we left behind 10% of the tumor already, every treating oncologist from that moment on, which included me, knew that his prognosis is hopeless. No matter what we do, we will not add a single day to his survival. Yet, what followed? Extensive surgeries, aggressive chemo radiation therapies, immune manipulations, more chemo, more radiation, more immune therapies, more surgeries. He bears unsufferable toxicities, and then the tumors still continue to grow. Alas, we lost Andrew literally within 16 months from diagnosis, as predicted on the day of diagnosis, that he'll survive 16 to 18 months. He was 23 years old. How we failed this boy. How is it possible? We are standing on the bedside of a 22-year-old at diagnosis and have nothing to offer. How badly, how badly. I can't stand it. This poor boy had the most painful death imaginable. But for me, Andrew had a particular significance because he was my daughter's best friend. Andrew was not Shehrazad's boyfriend because our Andrew is gay, but he was her best friend since childhood. They're growing up together. When they're in college, my daughter went to undergrad Columbia, he goes to undergrad NYU, but he took the junior year off to go to be trained in fashion design. Comes back, and instead of opening the boutique he had been dreaming of all his life, he ends up out of the blue with this brain cancer. So the problem is that all the 22-year-olds are now sitting by his bedside at Sloan Kettering and watching the disease take him apart piece by piece over 16 months. All the children have PTSD. They are all in therapy now. Can't get over what they witnessed. But imagine me talking to Andrew's mother. Is honesty a choice? Because what were the choices for this poor boy? Either you die of the cancer or you die of the treatment. And I advised treatment also. Why? Because death from cancer is much worse. Imagine a tumor growing in the brain which causes the unimaginable headaches. At least with radiation, we have the effect of radiation, but we reduce the tumor size and they die of the effects. Why are these the only two choices? This is my question. So I want to summarize that this is not a one-case story. Let's look at the entire cancer paradigm right now, where we are. Great news, we cure 60% of all newly diagnosed cases. That's great. But my question is, why are we curing those? Because they were detected early. What about the 40% who are detected with advanced cancers to begin with? Because they're diagnosed with a primary tumor that's already metastasized somewhere. Their outcome is no different. But even the ones we are curing are coming at exacting physical and financial costs. The same over and over: surgery, chemo, radiation, that I call slash, poison, and burn. Now, I have been in the US practically 50 years already. I have seen over $1 trillion spent on cancer research in half a century. I've seen over 4 million papers in basic research published. But we have not made one iota of difference in this disease that Andrew suffered from. Do you know that his mother called me recently and she said now her best friend has glioblastoma multiforme, diagnosed stage 4. She said, but Azra, I called her and I said, don't worry, it's been almost 8 years since our Andrew died, and Azra must have some cure by now. How these things come as a slap in your face. Because year after year, decade after decade going by, and we are giving each other gold medals for wonderful publications, but what about the patient? Where are all the new treatments? No one is winning the war on cancer. Do you know when I was publishing my book, The First Cell, editor called me and said, listen, your most important sentence is on the second page. I said, what is it? He said, you say no one is winning the war on cancer. But you can laugh about it, but it's so terrible. What are we declaring winning about? Look at this. Age-adjusted mortality this year is the same as it was back in 1930. Yes, there's an incline and then a decline in mortality, but that parallels rise and fall in smoking and early detection measures. So it's not new treatments. And that's the tragedy. By the time cancer is diagnosed, it's developed into a mind-blowing complexity. 1 centimeter of tumor has 1 billion cells. 7 to 8 billion humans on Earth who are one species, but each is a little different. So are these billions of cells. A little bit heterogeneous. It has picked up a new mutation within the cancer itself. So killing these heterogeneous billions of cancer cells with one or a few drugs or a magic bullet is impossible. It hasn't happened. And so the question is, where do we go from here? There are practically daily proclamations of game-changing advances that promise revolutionary outcomes. The public reading such headlines believes them and is feeling reassured. If I don't have cancer, but I am reading these headlines, I'll be somehow lulled into a complacency that, fine, if I get brain cancer, of course I read in the paper. But most of the time, until you develop cancer, then you face the ghastly options. But then they and their families have no time to question why they've been led to believe in the fantastic advances. The reality is most of the progress being reported is in animals, and that is the fine print and not in the headlines. So where did we miss the boat? 5 million papers, so few of them brought compassionate treatments to a handful of patients. Why are 95% of our experimental trials failing? Why the obstinate refusal to take off the blinders and see the reality? I don't understand it. The same all over the world. The worst offender is the intellectual class, in my opinion, because they're the ones who are benefiting from the status quo. Everyone wants to blame the pharmaceutical industry or drug manufacturers. I think it's the academics who are leading the charge and who are supposed to be doing better. I'm very much included in all of this. Publications and grants depend upon individuals. And so, this is the problem. How do you take off the blinders if your salary depends on keeping the blinders on? If your next grant will only come in that area, you're bound to keep doing that. So, it's more comfortable to live with simpler, superficial realities. One can manipulate the complex reality of cancer for the purpose of dominance. Awareness and facing the truth bring intrinsic unrest. Rather than a scientific talk, more of a philosophical talk. But that's me, because I'm constantly questioning myself about why are we doing this? Because, you know, I see 40 cancer patients every week for all my life. And nothing grounds you into reality than the suffering of even one of them. I just showed you, you'll never forget him. Think of how many I have to deal with. I think Ghalib says it best. Rashk hai, आसाइश अरबाब ग़फ़लत पर असद. When he uses Asad, it means he wrote this before he is 24. रश्क है आसाइश अरबाब ग़फ़लत पर असद. इज़्तिराब दिल नसीब ख़ातिर आगाह है. रश्क है आसाइश अरबाब ग़फ़लत पर असद. इज़्तिराब दिल नसीब ख़ातिर. Asad envies the luxury and tranquility of the blissfully unaware. Heart's turmoil, the beqarari, it's the fate of those who are willing to be aware of the deeper truth. The woke, I'm not ashamed of the woke people or the woke idea. This is the problem all over the world, and this is why, Sherper, you mentioned my love for poetry. It's because reading one verse of Ghalib clarifies and thinks for me suddenly and puts them into place. And it gives me some kind of a relief thinking that a man who was 200 years ago is facing the same issues, because these are universal human issues that we all should be facing up to. And this is the book I wrote, which is my cry of lamentation, the first cell and the human costs of pursuing cancer to the last. Because I decided to look at everything related to cancer through the prism of human anguish. And that's what the book is all about. So, we can't continue to chase incremental changes. We need to do things radically different. The best solution is to go to the earliest point possible, where wellness seems to be morphing into illness. I want you all to know that if you think about it, our body has fantastic repair toolkits in it, which seem to function pretty well for the first 6-7 decades of our lives. We are, especially young people in this room, you know how badly you abuse your bodies with all kinds of risk-taking addictions and habits. But yet nothing much happens because the body keeps repairing it. But with age, everything is becoming decrepit. You know, I look at my face in the morning in the mirror and I say to myself, if this is what's happening outside, imagine what's happening inside my body. Every organ is developing the same wrinkles and the same problems. The issue is, you find something early, it's much easier to correct it. Cardiac surgery and cardiologists taught this in medicine 50 years ago. Don't wait for the heart attack to happen, because then you'll need a heart transplant. Try to find a coronary artery block as early as possible. But even that requires open heart surgery and coronary bypasses. So then they went a step further and said, let's prevent coronary artery disease by giving statins. So the real revolution in cardiac diseases, where mortality has come down by 70%. Now I showed you mortality for cancer. It hasn't budged. 1% decline over 30 years, but that's just brought us to the mortality rate of 1930s. And cardiology showed us that you could bring it down by 70% if you went for early detection, and even better than early detection, prevention. So this is the whole point. How do you go for wellness to illness transition? Even if you detect cancer at stage 1 of the disease, it still requires surgery or chemo or radiation. So stage 1 to me is too late. We need to go and find the first cell stage of cancer. But you see, the first cell doesn't come from nowhere. Cancer is such a well-orchestrated response to some kind of a stress that I am a firm believer that there is some stress, as Dr. Kusteni showed you also, inflammatory stress or something going on in the microenvironment that then is giving signals to the cell, either fight or flight kind of thing. Develop a strategy to survive or you're going to die. And so under stress, cells start developing a strategy to survive, and one of them ends up in giving it immortality and becoming cancer. But the point is that a lot has gone wrong before the first cell appeared. Those are the stress-induced perturbations that we should be able to pick up. For God's sake, you're wearing watches that can track every little thing in your body. Why is technology not being used for this kind of early detection? Rather, the entire focus is on constantly developing treatments for end-stage disease. I insist that all of medicine has to shift from reactive treatment to proactive prevention. Not just cancer, everything in medicine has to move. Now, strategy for AML. Let me begin by saying that I landed in America as a young person, right out of medical school, and I arrived there in January, and my residency in medicine at the University of Maryland was going to start in July. I was so nervous that there's 6 months before I start my work. Somebody will cure cancer in 6 months, and I'll be left behind. I was really nervous about it. So I showed up at the cancer center and said to them that, please, I want to be involved in cancer research because I have 6 months. So they took pity on me, and I started in pediatric oncology. Within 3 months, they threw me out because I was crying the whole time. And they said, you can't survive pediatric oncology, go to the adult service. So I arrived in the adult oncology service, and the first thing I noticed there was that the same drugs I was using that cured leukemia in children had no effect in adults. Why? Because imagine the cells of a child are nascent virgin cells. Cells of a 70-year-old have 1,000 cuts in them. So they metabolize the same drugs differently. And at that age, I realized that even a littler version of ourselves cannot serve as a model for our adult self. If that is the case, then what I am going through when I develop cancer will be very different than what you go through if you develop cancer. That means even I can't serve as a model for you. Why? Because your lifestyle is different. You may be exercising more than me, you may be taking different drugs than me, etc. So then, what is the solution? It's so complicated, but in a way it's not. Because it's what Norbert Wiener said about cybernetics in 1940. He said, the best model for a cat is another cat, preferably the same one. In other words, you need to personalize medicine, which means that you need to monitor each individual continuously for their signals of stress and for their signals of any perturbations, and keep trying to fix them. And that is the future of medicine, and that is coming for sure. This is why when I started in acute myeloid leukemia and realized that this is one of the deadliest diseases for glioblastoma multiforme and for AML, we have made 0.00 advance. 0. And I'm not exaggerating here. The same 2 drugs I was using in 1977, Ali, combination known as 7 and 3, 7 days of one, 3 days of another. In 2024, that is the exact 2 drugs I'm using. In 1977, the survival, 5-year survival for these patients was 26%. Today it's 28%. So I wasn't wrong in thinking that in my lifetime no one's going to cure this disease. And so I said to myself, the only good news you can give a cancer patient is we found it early. So how do you find AML early? Leukemia, by the time it becomes apparent, you have billions of cells all over. Well, find people who are at risk of developing leukemia. They don't have the disease yet, but they are at risk, like Dr. Kusteni described to you, that whole model. The idea is, before they develop the deadly disease, you can prevent it by interception. And this became my mantra in 1984. In 1984, I started on number 1, find the disease early, and number 2, only study human samples. Now, mice and animals are fantastic for studying the biology. You just saw in Dr. Kusteni's talk how beautifully she developed the whole concept. To study mechanisms, to study biology, to study molecular biology. But ultimately, she tested everything on human cells. Now is ready to carry with us a human trial. And that is exactly the kind of synergy that has to exist everywhere. This is true translational research. When colleagues like Stevrula and I talk on a daily basis, we can yell at each other, we can disagree, but then we both have that same purpose, that in the end everything has to be for the patient. And this is why Stevrula is sitting in this room. Think of it. How many people tried to scare her about coming to Lahore right now? Everybody and their grandmother were showing us these smog-ridden pictures we were getting. Our children who become like Nazi generals when we are older. And the children are, Mommy, what are you thinking? You're going to Lahore right now? By the way, I read this thing yesterday for them, when too many people asked me, why are you really going to Lahore? ज़माने को ज़माने की पड़ी है, हमें वादा निभाने की पड़ी है. ज़माने को ज़माने की पड़ी है, हमें वादा निभाने की पड़ी है. ये दुनिया चांद पर पहुंची हुई है, हमें लाहौर जाने की पड़ी है. बाबर साहब का हुक्म था, I couldn't say no. And for me, It's such a wonderful chance to come home. But for Stevrula, there was no reason except to say, Azra, you are going, I'm going. I trust you. How many times I called you and said, are you sure you're coming? She goes, yes, if you're going, I'm going. I'm not scared. I want to go there. I mean, and we should really thank her. Please, let's give her a round of applause. Anyone else with a weaker digestion would have dropped out months ago, but not you. I'm so proud of you. Thank you. Well, what I was saying was, I have two messages that everyone in this room should take from me today. The first is, find cancer as early as possible. Even before the first cell stage, even at the stage where the stage is being set for the appearance of the first cell, the -1 stage. And the second important message I want to give is that if you want to develop drugs for humans, then you have to study human tissues. And so back in 1984, thankfully I was an immigrant. I hadn't been trained in that culture. So I was able to think as an outsider. Okay, if I'm going to want to study and treat and develop any understanding of these diseases, I need human tissues, I need samples. So I just started banking blood, marrow, biopsies, saliva on my patients, anything I could get. And today I have over 60,000 samples that have been longitudinally obtained as patients traverse this journey from thousands of patients that I am following. These are the stories I tell in the book, The First Cell. And what it has done for me, do you know that to this day, I work as an intern in my clinic. Stevrula comes and sees me often. Every single bone marrow I do with my own hands to this day. Some days I'm doing 8 to 10 bone marrow procedures on my patients. Why is that? Because I realized that the day I stop taking care of patients myself, the entire inspiration will die from me. Every question has to start from that bed. And what I'm doing to that patient, you need to be reminded how painful it is. That you learn to respect every single cell in that freezer. Such an important thing that patients do for me. It's a painful procedure, but when I ask them, are you willing to give extra marrow for your research? Not one person has ever said no to me. Some will ask, Dr. Raza, will it help me? I go, probably not. Will it help someone else? Yes, for sure. Okay, I trust you. I want to recount one thing from the book before we go on, about trust. Mr. Jinnah, one of my great heroes, you know, he could barely speak Urdu. He always spoke in chaste, pristine English. So once he had gone to Agra to argue some court case, and the people in Agra found out that Mr. Jinnah is in town. So this is in 1942, I believe. So they held a huge function in the park where 10,000 Muslims collected to hear Mr. Jinnah. He spoke for 2 hours in very difficult English, with his British accent, with his clipped British accent. Only 500 people had a passing knowledge of English in that crowd, and maybe 50 understood every word. The rest of the 9,500 people had zero idea what this man is saying. Yet there was pin drop silence. So at the end of the talk, one of the journalists was very intrigued, and he went to a common man who had not understood a word and said, "Did you understand anything Mr. Jinnah said?" He said, "No, not a word." So the journalist said, "Then how come you were sitting as if you were mesmerized and didn't say boo?" And the man said, "Yes, I didn't understand anything that Mr. Jinnah was saying, but I'm confident that everything he was saying is for my own good. How beautiful. That trust Mr. Jinnah built, not overnight, by his repeated actions. He showed his care. It wasn't important that people were understanding every word of his English, because they had such faith. That's the kind of trust a doctor has to inspire in the patients. That patients don't understand all the nuances of the disease that you're going to describe to them, all the statistics you're going to throw their way, but they must have confidence that whatever Dr. Raza is thinking of doing for me is for my good. And are we living up to that? This is what bothers me every day. That this poor woman who's sitting here and saying, do whatever you want, give me all the chemotherapy you think is best. Am I being fair? She doesn't know. She doesn't know what's coming for her. I do. And with what conscience am I supposed to do this? If I got acute myeloid leukemia today, the disease I have been trying to treat for 50 years, you know what I would do? I would take all the treatments. Because as humans, we have no choice. At least that will give me some chance. I will do the same, because I'm no different. And this has to change. These realizations made me into a rebellious person. And the book I have written is an insider coming out, hitting hard at the insiders. And that is taking a real risk and a real sort of confrontation with establishment. But it's hard to complain and to attack me, because I'm seeing 30 to 40 cancer patients. I have a research lab. I have actually a company. I am a cancer widow. Cancer entered my own home when my daughter's 4 years old and left us, the two of us, to a life of total loneliness and isolation. So cancer has wreaked havoc in my own home. Who's going to lecture me about any angle of cancer? It's very hard. And this is why I am able to say all these things. This is why I feel it is my duty to say it. If I don't, who will? We have to challenge. We have to push the boundaries. I want to leave young people with nothing else than just with this message. You have to be authentic. You have to be sincere to your purpose. Don't expect any reward, any return. I feel like a total failure every single day of my life, because I'm the one who's going to go back and go to clinic. Till the last day, till we took off from JFK, I was answering my patients on the phone. I'm here and I'm getting constant messages from my clinic, and I'm putting out fires. Devrul asked me, what are you doing? I said, exactly this, putting out fires in my clinic right now. That's who I am responsible for. There is no reward that is greater than just being able to even walk them through that difficult journey is in itself a reward. Not just the cure part, but that walk. Because the only Zen you find on top of the mountains is the Zen you brought with yourself. And that's the journey that I'm talking about. So important. Let me just end by saying, I've been talking about what are the stress markers that cause the first cell to develop. These are things that could be shed into the blood. And my idea is, why not use blood as a window into disease? Because everything gets shed into the blood in the end. Pieces of protein, DNA. There's very strong evidence, including our own work, indicating that early warning biomarkers exist, whose presence can alert that the first cell stage has begun. 60,000 serial samples are available. We can go, and in the discovery phase, we can take patients with MDS who developed AML. Some developed it in a short time, some took longer. Use normal individuals also, and now go and perform all the multi-omic studies, proteomics, transcriptomics, metabolomics, glycomics, methylation, etc. Use the petabytes of data that are going to come out of this, imagine, is going to be handled only by artificial intelligence. But we can develop signatures that are simpler and say that when this particular combinations of proteins, DNA, RNA, metabolites are found in the blood, it's alerting us to this. And for each individually, each person individually. So with these ideas, we are contemplating a transformative approach for cancer. But guys, Van Gogh could stand by himself and paint the starry nights. Art is I, but science is we. You cannot exist in isolation. Many people ask me, can we do this cancer research in, say, any university in Pakistan? The individuals are so smart. It's not a lack of talent or reason or thinking. Even you can have all the instruments and things in your lab, but the problem is the infrastructure that you need doesn't exist. It has to be a community effort. It takes a village to do one single meaningful biological complex experiment. It's not like I'll pick up the phone and say, okay, send to the Columbia Core Lab for the proteomics these number of samples. I mean, that's how easy it has to be able to do research. So I want to take my hats off to people at this institution who, despite all the odds, are continuing the push. It's unbelievable. I want to say that I felt so moved and so impressed by when I was taken for a walk around the laboratories when Shepherd and showed me and told me a lot of these, the kinds of things you guys are doing. And then the poster presentations that I witnessed from the young students, your PhD students, I can't get over. It's exactly like being in the United States. And I told you that please have Dr. Kosteni, she must see some of those posters today. And that to me is phenomenal, that despite all the odds, so you don't need role models from outside, you don't need to look outside anyway. You have enough people right here in this institution who are providing these guidelines for you. But building a consensus for me became very important because I can't be the only voice saying the same thing. But you know, I'm an old hag, so I can pick up the phone and call up my colleagues, and I did just that. And I called up my colleagues, created an oncology think tank, and 30 leaders from academia and industry, MD Anderson, Harvard, University of Chicago, Hopkins, Yale, Stanford is there too. They joined a little late. But I called up leaders of these institutions myself, and I said, hey, point out the fatal flaw in my argument that we need to find cancer early and we need to study human samples. Either point out the fatal flaw or join the revolution. Everyone joined the revolution. So I was able to build a consensus of people now from all of these institutions agreeing that those are the right things to do. But then I brought industry participants. These are the most important people who are working in early detection of cancer. We had 17 two-hour-long weekly meetings, and we published an opinion paper that was published in Scientific American. And the conclusion of this think tank was exactly what you just heard Stebrula say and I say. You find cancer early, much before stage 1, at the first cell stage. So once I had this consensus and the marching orders, what should be the strategy? The ideal would be to monitor the health of every one of you till you develop any disease. But that's going to be a very difficult task because some may not develop anything for 50 years. So we decide to begin with a population that is at risk. And liquid cancers, we already showed you that I have the largest tissue repository already for liquid cancers. For solid cancers, Who is at risk? Do you know that 1 in 5 new cancers appear in a cancer survivor? 20% of all cancers newly diagnosed are in a person who has had cancer before. In this room, there may be many of you who either have had cancer or know someone with cancer. Don't panic, because for an individual who has survived cancer, the risk is only 13% higher. But in actual diagnosed cases, when you look at it, then in those cases, 1 in 5, that's a huge number. So if you just do the math, if there's 2 million new cases diagnosed in the US this year, 400,000 are in a cancer survivors. Why don't we just monitor them? Because they'll develop it pretty fast, and they're followed anyway regularly. Everyone goes for a checkup and follow up to the cancer center. All we have to do is just draw some blood. So we started collecting samples, and do you know, 3 years ago I started this, and already we have so many new solid cancers. So now we have gone from wellness to illness. What we need to do is to study serial samples from the tissue repository that I already have, and now from the solid cancer tissue repository I am collecting. We need to do all the multi-omics, metabolome and methylome, and we are capturing the first cells on filter. I didn't have time to talk about that today, but yesterday I presented this this part of the work at Fatma Jinnah Medical University. And we can use AI to analyze the petabytes of data. Now, the idea is to go from treatment to prevention. You can study at the DNA level, RNA level, at proteins and metabolites level, in different compartments. Why just blood? We are looking at all accessible compartments: plasma, serum, saliva, stool, marrow, urine, peripheral blood, exosomes. And you study all these things on everybody individually. And that will allow us then for AI to come up by their complicated platforms on which they've been trained to come up with a signature that we don't understand, but AI, through its analysis, will tell us that this is the signature you need for early detection. And that early detection markers, once they are put together into a definitive treatment pattern to intervene at that early stage where even lifestyle changes can make a difference. You can't say that, oh, someone has developed lung cancer because they've been smoking for years, and now if they stop smoking, cancer will go away. No, stop smoking was the idea they should have done 20 years ago, right? So that's the whole point, that lifestyle changes like stop smoking, exercising, eating healthy, etc., work at a certain stage. And so I'm very excited about, sorry to make you dizzy with this, but that was the purpose, to wake you up and say this is happening, this can happen, we are very excited about it. And I think that the same model has to apply for every disease. And you don't have to do another tissue repository for the same model, because think of it. Let's say I have serial samples on patients who had pre-leukemia and then developed leukemia. But not everybody developed leukemia. Some did. Some developed cancer. And for them, we can target the cancer at the first stage, and we have implantable sensors and targeting devices. But then we have samples saved on them for biomarkers. But those people who don't develop cancer, some of them can develop dementia, diabetes, heart disease, other chronic diseases, arthritis. Guess what? We have samples on all of them now from before and after. So the same tissue repository can serve as a repository for multi-omics on patients who develop dementia. What were the signals that appeared before and after in their cases? In other words, and that's what I was saying, that you could reduce inflammation, you could make simple lifestyle changes and use drugs like metformin and aspirin and Ozempic, things that will work at that stage to prevent cancer. That's the whole idea. This is the team and some of our supporters here. some of the scientists working in my company, in my lab, and there is Professor Kusteni standing with me. We are always together. Thank you so much, everybody, for your attention. I'm going to stop here. Happy to take any questions.